Good afternoon. I'm calling to order today's informational hearing of the Public Health and Developmental Services Committee sitting in special session. Good afternoon to all of my colleagues, members, and staff, and all the stakeholders that are here today. This is a hearing on ABX 220, and it's an informational hearing only. That means that there will be no vote taken on this bill today. The proposal that we're here to discuss and hear about and ask questions about is the administration's managed care organization financing reform. It's the first opportunity to ask questions and understand the mechanics of the proposed financing reform, and we have the honor of having Jennifer Kent, Director of the Department of Healthcare Services, here to provide testimony and answer member questions on the elements of this financing reform. And I also am well aware that many of you here up on the dais, as well as joining us today for the hearing, are interested in the developmental disabilities services system. And as you are aware, ABX 220 contains no provisions relating to developmental disability services. However, the Assembly remains committed to a substantial investment in the developmental disability services system, as big and as broad-based as possible, and work is being done right now in an effort to get there and achieve that outcome. It's just not formally a part of this bill that we're hearing today. With that, we can commence our hearing, and I'd like to open it up to members. If members have remarks, they're not required. Okay, so we'll jump into it, and I'm presenting the bill, so I'm gonna come down, and Vice Chair Assemblymember Mainshine is going to take over.
Thank you very much, Mr. Chairman. We will go ahead and call item number 1, and Chairman Bonta will be presenting.
Good afternoon, members. ABX 220 is the administration's managed care organization financing reform, and the proposed legislation would implement a tax reform proposal to restructure the taxes paid by managed care plans. This includes a replacement managed care organization tax for the tax expiring at the end of June 2016 this year, and replaces other taxes currently paid by the health plan industry. This tax reform proposal provides 3 years of critical funding for the Medi-Cal program, allowing for the continued expanded health care coverage to millions of Californians and protecting programs from cuts during future budget deficits. I have with me today Jennifer Kent, Director of the Department of Healthcare Services, to answer any questions you may have on the proposal.
Ms. Kent?
Sure. Good afternoon, Mr. Chair and members. Jennifer Kent, DHCS Director. I just want to, I'm happy to take questions. I wanted to stress that it has been a process in which we have been in deep discussions regarding the complexity of this particular proposal for many, many months. And so with that, I really want to both acknowledge the work that has been done with our partners at the Department of Finance because of the other taxation pieces of the proposal in particular, but also want to acknowledge the support from the health plan industry in terms of they have been open and willing to talk with us through several iterations of the model that we have been working on over the course of many, many months. And so with that, we believe that the proposal that is really embedded in this bill is indicative of a lot of both collaboration, cooperation, and is a really carefully balanced approach between affordability on the market more broadly in California, as well as the sustainability of funding in Medi-Cal. So with that, I will take your questions. Thank you.
And maybe if I could ask you, before we go to questions, if you could just walk the committee through kind of what the proposal is.
Sure.
You don't have to go necessarily in. We can get to questions to go in depth, but I think it might be helpful for the entire committee to walk through at least the kind of the head bullet points or the highlights of it.
Okay, great. For purposes of historical background, California has had 3 managed care funding and financing proposals in the past. The first one was a quality fee that was done through an act of Congress. The second was a gross premiums tax proposal that was done in 2008, 2009. And then we moved that gross premiums tax proposal to a sales tax formulation, which is the one that is currently in effect. In August of 2014, the federal government sent a letter to all state Medicaid departments saying if you have a managed care tax in which it's not broad-based and uniform, you have a legislative session to change that to come into compliance with federal provider tax rules. So that's really what the genesis of the conversation within California. That's how we started down this path. What this proposal reflects is a broad-based and uniform tax across the entire managed care industry. There are certain federal requirements that can be waived, and so part of our proposal would be waiving it from the standpoint that there are different tier amounts depending on what kind of plan it is and what kind of enrollment it's based on. It is an enrollment-based tax proposal as opposed to the previous taxations have been on revenue or gross premiums. One of the main changes that we have made in this proposal was our previous iterations had been seeking to make this an enrollment-based tax done on quarterly enrollment reports from the health plans. We have now made that what we call a static model. It assures both stability to the plans and that they know for the next 3 years what amount of taxation will be on them based on a static piece of data, as well as from the state perspective, we know exactly how much revenue will be generated by this. There have been additional changes in terms of, the simplest way to say this is we are proposing essentially a tax swap by saying to the plans, if you pay the gross premiums tax or the corporate tax today, we will be removing the liability of those taxes on you and instead replacing it with a managed care organization tax. And so that has really been some of the fundamental successes that have really gotten us to this point, which is we were trying really hard, obviously, to listen to concerns about the affordability on the outside market. And so those tax changes in concert with the implementation of this tax, which is also still done on a tiered basis, generates approximately $1.3 billion in revenue to the Medi-Cal program on an annual basis. And we believe will meet with CMS requirements in terms of federal approvals.
Okay, thank you. Any other witnesses, Mr. Bonta, that you have that need to speak, or no?
Nope.
Okay. Next we will go to witnesses. I do want to just kind of reiterate, to the public and to the members, we're not going to have a motion or a second. We're not going to have something we're actually voting on here today. So, and also I know there is a Senate hearing later that other people are going to want to get to. So we will take testimony. But I would I would just urge that in light of the fact we won't be voting and there's not something specific to comment on, I just urge members or members of the public and the committee to keep that in mind. With that, we will turn it over so I'm just going to call witnesses in general. We don't have something to support or oppose, but I'll start with Mr. Luizas.
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans, or CAP. For background, CAP represents 48 public and private organizations that collectively provide healthcare services to over 25 million Californians, including over 10 million beneficiaries in the Medi-Cal Managed Care Program. That population in 2016 is expected to grow. And proper federal funding, of course, is critical to the success of the Medi-Cal program. CAP has taken a support position on AB 20. Our association has worked tirelessly with the administration and the legislature for well over a year to find a replacement for our current MCO tax. And the existing MCO tax is something that we supported in its inception. Two priorities for the health plans as a part of this long discussion over the MCO tax have been to keep Medi-Cal revenue funding intact while also protecting the affordability of health care coverage. We appreciate the administration's willingness to consider our principles as part of our lengthy discussion. CAP supports the bill as it represents the best balance in achieving our shared goals. The bill before you includes two tax relief provisions. These relief provisions, coupled with other safeguards that are included in this bill, protect the affordability of health coverage while allowing the state to draw down considerable federal funding. So in short, I'll just keep it at that. We think this is an important measure, and we look forward to seeing it move at the appropriate time. Thank you.
Thank you. Further witnesses in support?
Good afternoon. Brianna Lehrman, Chief Executive Officer of the Local Health Plans of California, representing all 16 of the publicly financed, not-for-profit and community-based health plans serving the Medi-Cal managed care program, actually 70% of its beneficiaries. We have long paid the MCO tax and its prior iterations. We are in proud support of this MCO tax proposal as it secures a critical piece of funding for the Medi-Cal program and the nearly 11 million beneficiaries it serves. So we would echo CAP's comments and thank you.
Beth Capello, on behalf of Health Access California, we're also pleased to be here in support. Members, you were not here during the dark days of 2009-10 when we had a $38 billion deficit, but we were. We saw the cuts the Medi-Cal program took. We eliminated benefits, including adult dental and podiatric care and other important benefits for consumers. We cut rates severely. We would have eliminated eligibility if federal law had permitted us to do that. For us to have this funding source, which will provide stability and funding for a piece of the Medi-Cal funding, is a very important thing as we look forward over the next few years. And anyone who has looked at the gyrations in the stock market over the last few weeks appreciates that part of the general fund is dependent on capital gains. To have a piece of the Medi-Cal funding stabilized is important to us. And we too appreciate that the proposal that is before you should not have an impact on premiums. We have come before you repeatedly raising concerns about premiums having tripled in the last decade, and so we appreciate that that balance has been achieved in this proposal. Thank you.
Linda Way with Western Center on Law and Poverty in support of this proposal, as we believe it will avert potentially $1 billion in cuts to the Medi-Cal program, a critical program for over 12 million low-income Californians.
Thank you. Okay, further witnesses in support, name and organization only, please.
Thank you, Mr. Chair and members. Rick Rollins, representing ARCA, the Association of Regional Center Agencies, and also we're a proud member of the Lanterman Coalition. We're here today to support this effort. We recognize that without it, the state faces a potential huge loss of federal dollars into the program. We look forward to continuing to work with all of you to ensure that the developmental disabilities community receives a respectable share of proceeds from this solution. I know you all have heard our pleas and the facts that we presented to you, and we look forward to working with everyone on this committee throughout the legislative process. Thank you.
Thank you. Good afternoon. Farrah McDade Ting from the California State Association of Counties, representing California's 58 counties, in support.
Thank you.
Mr. Chair and members, Julian Voris here on behalf of the urban counties of California, here in strong support. Thank you.
Good afternoon. Dan Chick from HealthNet. We're in support. Thank you. Good afternoon. Andrew Kiefer with Blue Shield of California, and we are in support.
Teresa Stark with Kaiser Permanente. We are technically neutral, but we would echo all of the previous comments about the fact this is a fair and balanced proposal that brings important revenue to the Medi-Cal program and won't negatively impact their purchasers and will have an overall positive impact on the marketplace. Thank you.
Barry Giardini with the California Disability Services Association, as well as a proud member of the Lanterman Coalition. I'd like to echo what Mr. Rollins said regarding funding for the disability or developmentally disabled out of this revenue. Thank you very much.
Mr. Chair and members, Eduardo Martinez on behalf of the California Medical Association. We are in support of the bill. I want to urge your support at the appropriate time, and kudos to the administration and all the stakeholders for getting this done.
Good afternoon. Brianna Pittman with the California Dental Association, here in support of the bill as a form of stable funding for the Dental Cal program, and just echo the comments of Eduardo and thanking everyone for working on this.
Thank you, Mr. Chairman. Members, Dwight Hanson on behalf of the Alliance, a statewide coalition of providers of services to people with developmental disabilities. Thank you very much to each of your offices. We work closely with you and the administration to include developmental disability services in this MCO tax. We really don't care what the source of the revenue is. This field is in bad way and they need help, and we thank you for allowing us to be at the table for this discussion.
Thank you, Mr. Chair and members. Mady Lee on behalf of Sutter Health, also in support of this fair and balanced proposal. Again, want to echo the appreciation that we have for getting to this point. Thank you.
Christina Romero on behalf of Planned Parenthood Affiliates of California. Strongly support this measure and appreciate the work that's been done, especially considering it would leave a $1.1 billion hole in the Medi-Cal budget.
Okay. Any further witnesses in support? Seeing none. Any witnesses in opposition? Yep.
Good afternoon, Mr. Chair and members. Ignacio Hernandez on behalf of the Consumer Watchdog. We have some serious concerns with the proposal as it's currently drafted. Let me clarify a couple of things. One is we are fully supportive of the work that has been done to try to address the gap in Medi-Cal and the MCO tax. We understand it's been a lot of work, a lot of stakeholders, lots of discussions, and we think that that is laudable and that is a warranted goal. Our concern is that this final the draft that's before you today allows insurers and health plans to get out from under the gross premium tax for a minimum of 3 years, possibly longer. And that is something that we simply cannot stand by. The gross premium tax, as we've calculated, could bring in over $1.5 billion into state coffers going forward each year. And we believe that that's money that should come in, and that's money that could be used to help fill the gap or to do a number of other things. I think it's important to keep in mind that I know these discussions have been ongoing for over a year, but there have been some developments over the last few months. And one, for example, is in September, in a court case in LA, appellate court decided that there was a basis to impose the gross premium tax on entities who claim to be exempt from it because they are health service plans. And those are two of the major entities in California. The appellate court decided that they could be subject to the tax, the gross premium tax, and send it back down to the trial court to deal with some of the specifics to see if they meet the threshold definition that the appellate court had decided. The concern here is that this bill, as it's currently drafted, would allow those entities and others to get out from under the gross premium tax, notwithstanding the fact that the Court of Appeal or the appellate court just stated that they need to pay it. We believe that a better solution would be to find a way to ensure the gross premium tax is collected from all appropriate entities, and also find a way to fill this gap through an MCO tax or some other approach to it. We don't think that we should sacrifice the gross premium tax to obtain this deal. And the other thing to keep in mind is I believe the analysis is about $90 million to the benefit of health insurance, health plans out of the current draft of the bill. That strikes us as a little bit odd. We understand maybe why they would support that, especially when they are going to get out from under $1.5 billion, if not more, annual tax. So we think that there's a better balance that can be struck, and we do appreciate all the work that's been done and always open to having discussions. Thank you.
Thank you.
Mr. Chairman, members of the committee, Fred Main on behalf of Cigna Life and Health Insurance Company. We are in the position today of opposing AB X220 and the MCO tax proposal as currently drafted. We have worked for a year trying to find a proposal that would impose the MCO tax, of which we were willing to pay. as long as there were not competitive disadvantages established amongst individual taxpayers. Unfortunately, in its current version, we do not believe that AB X220 meets that. We have been working with the Department of Managed Healthcare specifically for a year on a competitive disadvantage issue on the application of taxes specifically to products that Cigna has in the market. Unfortunately, the exemption provided in the bill would benefit some plans but not all plans. While we cannot discuss the product design in this setting, we are opposed to the bill moving forward until it's addressed. We do believe that language can address this issue, and I want to emphasize that address it as a tax issue and how the MCO tax and the offset of the bank and corporation tax provisions would work. This is not a policy issue that we're addressing. We understand that the timing is late, but because, as an example, this hearing is an informational hearing, we would hope that there's still an opportunity to provide this language and allow us to remove our opposition. Thank you very much.
Thank you. Further witnesses in opposition? Name and organization. Okay. Seeing none. Okay. Seeing none, I will get to the committee. I want to briefly. I want to make some brief comments, and then I'll turn it. Ms. Bonilla will be next. First, I want to. I really want to extend my compliments to the administration for working so hard on this. They've been great to work with, and I know have really tried to tackle a tough issue, and I want to commend them. I also want to really praise, extend commendation to the plans who have worked so hard on this as well. There's been a lot of moving parts here, and it's been complicated, and they've really come to the table in an attempt to work through this. I think certainly for myself, and I know for many other members of the committee, that this end up providing a net benefit to consumers is critical. Ms. Capel had mentioned, and I concur with, that we want to be concerned that there's not an uptick in premiums. That's an important principle. I know that I have, and I know that others share that as well. And so that's been kept in mind throughout the negotiations, I think, is significant as well. And we want to make sure that continues as we move forward on this. I mean, we're not there yet. I think there's been a lot of progress made. To see this many people come forward who have spent the incredible amount of hours, I think is a very significant step. And so as we move closer on this, as we continue to negotiate through all this, the spirit that has surrounded this issue from all the players is really striking. So I'm pleased with that for all the people who are here today to do this about working through a complicated problem. And it seems like we're on our way to hopefully providing a solution there. So I just want to see that continue as well. So with that, I'll turn it over to questions and comments from the committee. I'll start with Ms. Bonilla.
Thank you. I just need some clarification. If perhaps you could walk us through the tiers, the taxing tiers that are listed on page 2, that would be very helpful. And then also address just the mechanics of how this tax is actually going to be collected.
So your page 2 might be my page 1.
Yes.
But just as if we're going to give accolades for people, the person that actually created this model is Mary Cantwell, who's my chief deputy and the state's Medicaid director. And so, as I like to say, if it were up to me to have created this, I'd still be sitting in front of my computer screen with a blank Excel spreadsheet, wondering how I enter names into the model. So, how the model and the tiers are created is that it's enrollment based, and so there's a tier in which we are taxing Medi-Cal lives. So when you see that tier amount of Medi-Cal for under 2 million members, there's a taxation amount assigned to that. And then when you get between 2 and 4 million lives, that's a different amount. And then for tiers over that, it's a different taxed amount. There's other tiers, so we basically broke the model into 3 tiers. There's the Medi-Cal side where we are taxing the Medi-Cal enrollment on plans. The other includes other, so other lines of business, other lives that are not Medi-Cal lives. And obviously we were very mindful of the affordability issues involved on what happens to that. And then there's a third tier, which is it's an alternative healthcare service plan. This is in recognition of there are certain plans, and again, the challenge of this entire negotiation has been we have 48 plans that are a part of this discussion. They are in different geographic regions. They are different sizes. They are constructed differently. They have different tax treatment. And so there are 3 tiers in this model that is indicative of trying to be mindful of where these plans sit. And then I would also say that these amounts may look a little different, but there's also some statistical tests that we have to meet for purposes of federal approval. So that is why some of the amounts look a little different in terms of when you run the model. We have to meet what's known as a B1, B2 test. And so this model meets those tests. And so that's why the amounts are different.
And then to the mechanics of the
Sure.
collection.
So we would submit a request to the federal government, and once we get approval from that, we would be sending out and collecting revenue to the plans based on a quarterly basis. And so on a quarterly time frame, they would be submitting revenues to us, and then we would be putting it into a special fund. We would the Medi-Cal plans, we actually have to pay back the amount of that tax, which has been consistent with why these other models have worked in the past, is that the plans receive that back through their rates. And then the rest of the money is used in the general fund to match and draw down federal dollars. So it would be on a quarterly basis that tax would be collected from the plans.
Mm-hmm. And then could you just explain the sunset provision that you have in the bill?
Sure. So I think this was something that I think the plans were always interested in seeing as part of the original proposal. There was not a sunset date proposed. I think we both, from the administration and from the industry, would like to see a sunset in place because I think the evolution of the market is going to continue to move. Plans are being acquired or transacting business in different ways. And because the model is static, meaning the enrollment is locked between 2 set dates, we want to be able to revisit that enrollment data in 3 years. So that justifies looking for just a 3-year sunset.
Thank you. And I do have another question here on what's your confidence level around the fact that CMS would actually grant a 2-year waiver on the broad-based and uniformity requirement?
So that is the provider rules and regulations that set forth a provider tax is you have to meet certain statistical tests. So we are confident that the model that we have meets all of those tests. So it's essentially a fairly straightforward request to the federal government of here's the model. We are asking for these 2 things to be waived, but here are the ways in which the model meets those tests, and that's what we have constructed.
So you have a high level of confidence in
Yes. We are giving them a model that they can approve, yes.
And then just one final question. In opposition, the issue was raised of the foregoing the gross premium tax for those years. So could you just go back over the issue of and perhaps the amount that was used there was that it was I think $1.5 billion over 3 years that would be not collected versus what this plan is achieving. Can you just perhaps give the rationale for the way this has been designed?
Sure. So I can't speak to the number that was used by the opposing testimony, but when we looked and this model and our assumptions and fiscal calculations are using public data, so we went to the Board of Equalization and looked at what those health plans had paid in gross premiums tax in the past year, and so that is how we arrived at the numbers that we arrived at in terms of those tax changes. I think when you, and I'm not not an expert on the court case, and so I can't necessarily speak to that. But when we built our model, we looked and said, if plans are being regulated on either the Department of Insurance or on the Department of Managed Healthcare, sometimes they sit on both sides. The tax policy changes that we're seeking to change in this bill were very much intended to mitigate the imposition. We were very mindful of you don't add a tax onto an existing tax entity. And so what we were trying to do was be very mindful, again, back to the affordability issue. And so I think we were also trying to ensure that it's palatable to the legislature, which is obviously this is a 2/3 vote. And some of the changes in the gross premiums tax would, if it was a broad-based flat tax or something like that, I think it would just have difficulty in a lot of regards, both from an affordability standpoint on the commercial market as well as just meeting, vote thresholds.
Thank you. That's eloquently explained. Appreciate it.
Thank you. Ms. Baker.
Thank you, Mr. Chairman, and I echo some of the accolades that you provided, and also the concern that you've raised as well as we go forward. This isn't really final, but this is something that we're going to need to make sure there is not a pass on to consumers seeing their premiums increase. To that end, I do have a question for Ms. Kent. Thank you. Regarding the 3-year, the data is static. So that's so that the plans have some predictability, and we have, as a state, some predictability of revenue. And the sunset is 3 years. So we're basically doing this for 1 3-year period, and nothing's changed. Is that correct? Mm-hmm. Okay. Is that enough time for us to have a real sense of, for a meaningful sunset? I'm not saying we should have this go off into perpetuity at all, but do you have a sense that we're setting this up for a reasonable amount of time to do this properly? And I have some additional questions after that.
Sure. I think, and my memory's a little rusty on the length of time that we have done the previous MCO taxes, but the sunsets have ranged anywhere between 3 and 5 years, and they may have been as low as 3. So I think what it allows for is for us to come back and gauge whether the revenue was. In the previous ones, they were based on revenues. This one allows us to look at the way the market's shifting, because, again, it's static. So I think 3 was the one thing that we all felt comfortable and agreed on.
And while the data will be static for that 3-year period, Medi-Cal won't be.
No.
And so to the extent that this is going to make sure that we're better taking care of our Medi-Cal needs, at least to the extent the MCO tax does that, there does seem to be a concern that we can't assure that 3-year period is going to handle the increase that we are very likely to see based on what was passed last year and continue growth in the program. I'm just concerned about that. Mm-hmm. I understand why it's static. I think there's good things about predictability, but the growth in Medi-Cal is not.
Correct. So the funds that are raised by this are not an insignificant piece of our overall general fund budget, but there's certainly, Medi-Cal is $18 to $19 billion. So this is a piece. It is not intended to be a complete and total solution. The one acknowledgement in the model is that due to the what we assume will be the growing changes in the tax policy changes that we're making, we did put a 5% growth inflator on each of the 3 years. It's still a static model, but we have accounted for a 5% trend upward, and so the tax is trending at 5%, which was basically, we looked at what Medi-Cal grew at, and so there are slight incremental changes in the model for each of the 3 years, even though the enrollment is static. So, but the plans, again, still get the certainty built on that static model that they know what their taxation level will be for each of those 3 years.
Okay. And one of the concerns that's been expressed to me about the proposal, and there are many, is that it grants authority to Department of Healthcare Services to make adjustments to the tax levels without any legislative input. Is that the 5%, or does it do that? Is that an incorrect claim?
It's a slightly different issue. So for purposes of seeking federal approval, for example, if our math was wrong on the model and they said we ran your B1, B2 statistical test and you simply are off by a factor, and your tax tier shouldn't be, $3, it should be $3.25. What we have said is, in order to meet federal approval, we need to be able to make those adjustments. And the plans had expressed concern about the flexibility to make those changes because of the nature of what that could or couldn't do to their overall tax liability. We had language in the hospital fee that is similar. What this bill reflects, though, is we have both capped the amount of funding on the other category in terms of the revenue of tax raised on other lines of business that are not Medi-Cal. And then we did a further amendment that said we can only go down if we have to make changes to meet federal approval. And so when you work with the model, once you actually do that, you understand that tax liability can ever only go in a downward effect if the feds ask us to change something.
And thank you. Last question. This may be for Mr. Bonta, and that is just a clarification. There's nothing in this current bill that funds the developmentally disabled. There's zero funding to developmentally disabled here.
That's correct. And there's separately work being done to get to a deal that will fund developmental disabilities. So within this, the formal technical specific parameters of ABX 220, it does not specify funding to developmental disabilities, but that's very fully and frontally on our radar and something we're addressing. Working to address.
Any further questions or comments from the committee? Seeing none. Again, thank you for the information to the committee. Thank you for the presentation. Thank you for the continued hard work from everybody who is here working away on this. Mr. Bonta, if you'd like to close, or if you'd like to just walk up here.
Thank you, folks. This, of course, was an informational hearing to vet the proposal, ask questions, hear from stakeholders, and have a robust dialogue about the components and mechanics of the administration's proposal. So thank you for participating in that. We obviously need a replacement for the existing expiring MCO tax, and this took a lot of work. So I want to just share my appreciation to the administration, to the plans for working on it and sticking to it and committing to getting to a place where we are today. We're in a place that we haven't been at before, and so we have an exciting opportunity in front of us to help make sure that our Medi-Cal program continues to receive funding that it's had in the past, that it doesn't have additional reductions in access to care, that it doesn't have cuts, and that as we continue to grow it, there's definitely other work we need to do to improve access and to strengthen Medi-Cal. But this is a very, very important component of it. So thank you for your discussion. And again, just reiterating, developmental disabilities is being addressed. We are working on it. We hope to have more specifics on what that looks like. So I don't want anyone leaving thinking that because it's not in this MCO tax bill that we talked about today, that it's not being addressed and worked on. It is. So thank you all for your participation today. We're adjourned.